Thank you very much, Peter, for that introduction. Good morning to all of you. It's a pleasure to be here, and I thank the organizers for inviting me. I'm going to talk about diagnostic challenges in tuberculosis. This is my declaration of interest. Now, TB is a disease that is difficult to diagnose for a variety of reasons. It's a chronic disease. There are few specific symptoms. It mimics many other disorders. Only bacteriological confirmation is deemed to be sufficiently specific to start the long-term treatment. Smear examination for almost a century, the mainstay of diagnosis, has low sensitivity. Culture has poor feasibility instead of long duration to get results. There are limitations of X-ray, especially in HIV. There are obvious health system challenges with regard to access, cost for diagnostics, laboratory requirements. And because this is the archetypal disease of poverty, there are also limited market incentives to develop new assays, even though they are appearing. Now, another thing to be aware of is the increasing awareness that the clinical expression of tuberculosis is not only highly variable between patients, but also within patients over time. And this is a graph from a recent review paper that sort of brings together the thinking over the past decade. And I think we're increasingly seeing that the classical dichotomy of latent TB infection, active TB, that there is actually a much more diverse picture, and that there are intermediate stages of incipient TB and subclinical TB in which there can be disease, there can probably even be transmission, but there are no, or there may be on and off symptoms. I think that's an important thing to remind when we talk about diagnostics. So what I'm going to talk about today is the current WHO endorsed assays, their strengths and limitations, the diagnostic target product profiles that the WHO, together with stakeholders, brought out a couple of years ago. And two of them, especially triage testing and diagnostic biomarkers, will get a little bit more attention. I won't address drug resistance testing, treatment monitoring, or hardly prediction of tuberculosis disease. So, obviously, the big improvement in TB diagnostics has been GeneXpert MTB-RIF. You're probably all aware of this. This is a within cartridge PCR that can basically be done in this tabletop device. You get a result within 2 hours, and it tells you not only whether there is Mycobacterium tuberculosis in the specimen, but also whether that bug is resistant to the most important drug that we use, which is rifampin. And the bar graph that you see underneath there is a summary of the data from already from 2014, and a meta-analysis of various studies that looked at pulmonary TB. And you see that there is a very good sensitivity, or pretty good sensitivity and specificity overall, that in smear-positive patients, sensitivity is very high, but in smear-negative patients, until recently the difficult to diagnose category, there is also a sensitivity of about 65 to 70%, and there are very minor differences between HIV and positive and HIV negative patients. And this has led, since 2010, when this was endorsed by the WHO, by a massive increase in use, as you can see in the market increase graph on the right. In addition to pulmonary TB, XPERT has proven useful for extrapulmonary TB. On the left, you see an overview of studies published a couple of years ago, various kind of cross-sectional studies that showed for non-pulmonary specimens a pretty good, again, sensitivity over 80%, good specificity. You see again that also in the smear-negative samples, there is a reasonable sensitivity of about 70%. And you can see that there is some variation between different types of tissue, for example, very high in lymph node tissue, but much lower in pleural fluid. And on the right-hand side, you see the data from a very recent meta-analysis that was done of studies that were done in what we call population of intended use. So it is actually cohorts of patients who present with symptoms. So what we call presumptive TB patients. So it's basically what you're actually interested in. And distinguished 3 different groups: TB meningitis, pleural TB, and genitourinary TB, on which were a lot of data, and that shows that for TB meningitis, the sensitivity was on the order of 70%, which is actually pretty good, although still obviously not good enough yet. For pleural TB, still only 50%, and for genitourinary TB, over 80%. The important thing to remind here, and this is always the problem with TB diagnostics, that the gold standard is not always gold, because it's usually like 2 positive cultures, whereas even culture may not be completely sensitive, may not have full 100% sensitivity. So when it is compared to a composite reference standard, for example, also takes into account whether a patient who is culture negative responds to treatment, sensitivity obviously becomes lower. Something that has received little attention is a test that was endorsed by WHO in 2016, which was the loop-mediated isothermal amplification, or LAM test, which is also a PCR-like test. It requires manual preparation. It's more sensitive to temperature, humidity, and so on. It doesn't test for drug resistance, but one of the advantages that it allows relatively high throughput without expensive instrumentation. And what you see down here is the data from a study from 3 countries, where you see on the very right-hand side that the overall sensitivity of 84% is not much lower than for expert, but that there is quite a variation between those 3 countries, which is a reflection of the fact that it requires manual preparation. So actually here, laboratory errors may come in. This was reason for WHO to endorse it for as an initial diagnostic test for adults suspected of pulmonary TB, but not to replace expert. So the new kid on the block is the Ultra cartridge, is the latest generation cartridge of expert. And this is data from the first sort of large study that came out of this by Susan Dorman, published last year, which was based on a head-to-head comparison in studies done in 8 countries on almost 1,500 presumptive TB patients, of whom a quarter was HIV positive, and overall 32% was culture positive. And what you see is that expert has improved sensitivity, or Ultra has improved sensitivity compared to the previous expert version. But that, and you can also see that in smear negative, culture positive patients, that difference is even more pronounced. But what you also see is that specificity, as often, is somewhat lower. And this probably has to do with the fact that with these so-called trace calls, so these are probably reflections of very low bacillary loads. And you can see here that if trace calls are not taken into account, sensitivity is lower. If it's made conditional, and you'll see that later on previous treatment, sensitivity is higher. And if the trace call is taken into account, that if you do the test the second time and the test is negative, you call it negative. The second time positive, you call it positive. So that's how the different ways that trace calls were dealt with in this study. And you see that this indeed explains quite some of the variation in sensitivity, but also, as you can see on the right-hand side, in specificity. And an important thing here is that the trace calls seem to be associated with previous TB treatment. So you can see here that the specificity is somewhat lower in the first few years after a previous treatment, which may point to detection of sort of residual DNA somewhere in the patient, or somewhere in the specimen, I should say. I think this is still things to be looked into. There have been a couple of other studies in addition to, here on the top, the study I just mentioned by Susan Dorman, 2 other studies that were published recently, one from South Africa in presumptive TB patients of whom the majority was HIV positive, and one from Switzerland for which HIV was not reported. And this is, you see here compared expert and Ultra, and you see that the sensitivity of expert was remarkably similar over the 3 studies, and the sensitivity for Ultra again was higher with a little bit of variation between the studies, but I think the overall story is the same. There's been been a few studies, but I think one study that already deserves mentioning on the use of Ultra on non-respiratory samples. And this was for TB meningitis, a study from Uganda by Barr et al. Published last year, That looked at 129 HIV-infected patients who were evaluated for meningitis, 22 confirmed cases of TB meningitis in that group. And here you see on top the sensitivity and then the specificity combining expert and ultra, and there you see a real advantage in terms of sensitivity of ultra over expert with a little bit loss of specificity. On the right-hand side, you see the Venn diagram of these cases. Here again, sensitivity was lower when compared to a composite reference standard. This compares it to culture. There's been another introduction, I think an important one, which is the urinary LAM lateral flow test. Those who saw my presentation yesterday already heard a little bit about it. So this is a lateral flow test that allows you to that tests for lipoarabinomannan, which is a cell wall constituent of Mycobacterium tuberculosis and can be excreted in urine. It can be done on uncentrifuged urine. A very simple test to do. What you see on the right-hand side is an overview of studies that were published in the WHO policy guidance. And in blue is Gene Expert, and in red is LAM, and in green the combination of the two. And what you see is that LAM clearly has a lower sensitivity, but if it's combined with Expert, it still increases the sensitivity, which probably has to do with this here. The fact that, especially in that group of patients in which expert may have, probably has incomplete sensitivity, patients with low bacillary loads, those are the patients with low CD4 counts, and especially in patients with low CD4 counts, there is a reasonable sensitivity of this LAM test. As you can see here on the very bottom, patients with CD4 counts below 100, sensitivity goes up to 56%. So it apparently fills a gap in the diagnostic repertoire, which was a reason for WHO to bring out this recommendation that lateral flow LAM may be used to assist in the diagnosis of TB and HIV positive adult in patients with signs and symptoms of TB, either pulmonary or extrapulmonary, who have a CD4 cell count below 100, or HIV positive patients who are seriously ill regardless of their CD4 count. And there have been a couple of studies that showed that adding urinary LAM to expert in the diagnostic algorithm actually improves survival in these patients. This was one of them, a study by Peter, that had been one last year, published also in the Lancet, the STEM trial by Gupta Wright, which basically showed the same thing, that there is a survival advantage, which has to do with the fact that now these patients are diagnosed who actually have a high risk of mortality, and actually a positive LAM in cohort studies was also associated with mortality. Now, does it mean we are there with regard to diagnostics? I think no. I think there are still remaining challenges, and I list a few of them. I think by far the most important is access. Even though these tests, for example, the expert tests or other PCR tests, there is still, I mean, despite the fact that they can be done without an extensive laboratory, it's still difficult to have them sort of on the spot where the patient is. And this slide here shows, this is from the WHO, and it actually shows on the top the estimated tuberculosis incidence worldwide, and the black line is the notification of new and relapse cases, so those TB patients who have been diagnosed and start on treatment that we know about. And you see there is this gap, and this gap is due to patients who are treated but not notified. There may be patients who have self-healed, but obviously also those patients who are not diagnosed and may even have died before. So there is a gap here, and probably that gap can only be filled if diagnostics is brought to the patient, so meet the patients where they present to care. Another challenge is sputum. These tests are generally sputum-based. I mean, especially for the vast majority of patients worldwide have pulmonary TB. And sputum is not a nice, it's not a nice medium, if you will. I mean, it's very difficult to get a good sputum, especially in critically ill patients, people living with HIV with low CD4 counts, the elderly and children. And these are the patients with very high TB rates. And then finally, there is a big problem with pediatric TB. Even though expert has made a difference, a little bit of a difference, as you can see here. This is a meta-analysis of 15 studies, large numbers of patients. And here, tests done on sputum may also be on induced sputum. And on top, you see that expert performs actually pretty well in those patients who are smear positive, but then smear obviously performs well as well because they are smear positive. But in smear negative patients there is clearly still sensitivity left to be desired. As you can see here, especially in the very young children that have difficulty covering up sputum and often have sort of difficult presentations of disease. Even with a sensitive instrument as GeneXpert, the sensitivity is still below 50%. Now, there have been a couple of developments here that I think should mention. There is a lot of interest now in doing GeneXpert or similar tests on stool samples. And I looked up a couple of studies that have been published lately. You see 5 studies here, one from Zimbabwe in older children, majority HIV positive, one from Pakistan, children up to 15 years, HIV not reported, one from Uganda, HIV not reported. To be honest, I couldn't get the paper as such, so I only looked at the abstract. The majority below 10 years of age, one from Kenya, young children, all HIV positive, one from South Africa, 13% HIV positive, also young children. What you see here is quite a variation in the sensitivity when this is tested on stool. And it seems to be, I think much of the variation is due to the small sample sizes, as you can see by the width of the confidence intervals. But I think what it also means is that probably the older children, it is probably a little bit easier to get a positive sample. In younger children, it's more difficult. But I think the most important distinction is with the top 4 studies with the bottom one. The bottom one was done without centrifugation. That's basically what you want. If you want to bring this test to a public health clinic, for example, you don't want to need to do centrifugation. So this was done with a specific way of treating stools, and then you see that even with 2 stool samples below there, you don't get above a sensitivity of 40%. So there is here also still work to be done. So WHO brought out a couple of years ago a target product profiles for new TB diagnostics. I think it was a very important process because what they basically did is tell the world what the TB world needs and tell test manufacturers, now if you can get a test that is as good as this, there is a market for you. So it's a very important process. I was fortunate to be part of that. And they basically came up with, and also a couple of other ones, but with regard to what we're talking about here today, with 3 TPP. So one was for sputum replacement test for tuberculosis detection. It's something that can be done for testing pulmonary TB, but, smear replacement, but improves upon what we currently have, what we've just shown. For pulmonary TB, which could be done at a microscopy center level, which would allow same-day diagnosis, it would also be able to test for drug resistance. A second one is a community-based triage test. I'll talk about that a little bit more. And finally, a non-sputum-based biomarker test, which I think is very, very important, which would be needed for pulmonary and extrapulmonary TB. It could be done ideally at the health post level, with or without a lab, and allow same-day diagnosis. And I'll start with the first one. So this is the smear-based test, it's sputum-based test, apologies for that error, and drug susceptibility assays. This is a graph from FIND, which basically shows the pipeline. You see there's an awful lot happening in this space. There is a lot coming up, a test that actually is either improved technology or sort of more frugal technology that better allows you to do it at the microscopy center at a lower level in healthcare. So the second one is those triage tests. I think those triage tests are very important. What they are meant to do is to triage patients and basically tell you now this patient either has or doesn't have an increased risk of having probability of having tuberculosis. So it's not your final diagnosis, but it tells you that this particular patient should have a test like GeneXpert or Ultra or whatever we have. So that also means, it means these should be very high sensitivity tests, but don't necessarily have to have a very high specificity. That then comes down to cost effectiveness. They should be point of care, that's the most important thing, and they should be inexpensive. That's what you see here in the receiver operator characteristics curve. You should be up there in the more to the right. High sensitivity, but not necessarily high specificity. Now there's a couple of potential candidates there. One is this one. It's X-ray with automated reading. which is called CAD, computer-assisted diagnosis. So this is because digital X-ray is coming up quickly. The incremental costs for doing digital X-ray are very, very low, but the problem is then radiologists. And so this software can read the chest X-ray image and then assign a probability score that this patient actually has tuberculosis, as you see here on the right. So probability score for the heat map up there is almost 100%, and down there it's only 18%. And that probability score then informs the next step. So you don't need a human reader where this expertise is scarce, which can be a great advantage, and it has potential for scaling up this technology. Now, there's been one meta-analysis already 2 years ago that looked at a couple of studies, and you can see here with various areas under the curve for that receiver-operator characteristic curve, although they were sort of in the same range, looking at different thresholds, but then showing that, as you would expect, that sensitivity can go up pretty high, but then obviously at the expense of lower specificity. And you want to have high sensitivity, but not too low specificity, obviously. Otherwise, it becomes very non-cost effective. So there's still a couple of studies going on. They're still trying to increase the sensitivity of this, and there are more vendors coming to the market. Another one that I already mentioned briefly yesterday is C-reactive protein. Now, this is a study from Uganda, prospective study of more than 1,000 HIV positive adults, CD4 count below 350, initiating ART, point-of-care CRP testing, and the reference standard was sputum culture. And here what you see is that in this population, you could, with a sensitivity of 89%, you would have a positive predictive value. So that means that that is basically the reverse of the number that you need to test in the next step in order to find one case. It's actually pretty high. It's 1 in 3. So this looks good. The problem, however, is that it looks good in this for this specific indication, pre-ART screening, but not necessarily for others. And this was shown in this meta-analysis by the same group very recently, where they showed that as you can see here, for 9 studies that, by the way, had quite some heterogeneity, and there were also quality issues, that outpatients, so just the first 3 categories, actually the sensitivity was high with a pretty sort of reasonable specificity, around 60 to 70%, which may be sort of okay for a triage test. And you see that reflected for the HIV positive outpatients in the graph up there. But when you look down there, the inpatients, so usually obviously the more ill patients, you see that sensitivity is lower, but specificity is much lower, which makes sense because these patients may have various other diseases that also gives a rise in CRP. Now, finally, diagnostic biomarkers. Now, there's a whole bunch of work going on in this field, and this was really very neatly summarized. If you're interested in this field, this is a must-read. It's Gerhard Wolzel's paper in Lancet Infectious Disease of last year. It's really a very good paper, and it gives you the entire story. I will just concentrate briefly on 2 types of markers, which is host protein markers and host gene expression. And the idea of biomarkers is really to improve test performance by combining them. We call that signatures, because then you can improve hopefully both sensitivity and specificity. So let's start with host protein markers. So they're basically a similar thing like CRP, that's also a host protein, but now they are combinations. And what you see on the left-hand side is an evaluation of 22 biomarkers that led to a 7-marker signature. You see a couple of sort of usual suspects there. CRP is among them, interferon gamma, IP10. And you see that the area under the curve is actually pretty good. So with this combination, you could actually reach a pretty good sensitivity and specificity. On the right-hand side, you see that came out of a proteomic analysis, a 6-marker signature with a whole bunch of proteins that I've actually personally never heard of. But that also performed reasonably well. So I think this is an interesting area, and hopefully we will see more of that in the near future. Now, host gene expression has gained a lot of interest. So this is based on genome-wide transcriptional biosignatures detected in whole blood. So it's actually easy to do. once the technology is out there. And it's actually shown, and this is from Gerd Walzer's overview, it's actually shown in many cases that it can discriminate TB disease from healthy controls, latent TB infection, other disease. And as you can see here, it looks pretty good. So without going into detail, sensitivity and specificities for some of those markers, they look pretty solid. But the problem is, look at the number of genes that are included in those signatures. We have 86, 44, 144, 51. So these are really very big sort of signatures. And obviously these are the problems for the future. So the problems that we see here is, first of all, this looks good, but they have not been validated yet, bar a few, and I'll mention them in other study sites of populations. But the other thing is, are they feasible in any way at point of care? Because if you have 144 gene signatures, it becomes genes in the signature becomes very difficult to come up with a technology that is sort of applicable in patient care to actually test for all of them. And then finally, the question, of course, is there sufficient discrimination between TB and other pulmonary diseases? Because very often those studies were not set out to test that. And with regard to that variation, there's a very interesting paper out recently in the Blue Journal that took 3 published signatures and actually adapted them to a PCR and then tested them in various cohorts. And in panel A, you'll see that they sort of more or less behave similarly in the same cohorts. But then you see them for each of the signatures, DIAC3, DIAC4, and this sort of ECS correlate of risk. And you see that they behave different in different cohorts from different countries. So that probably is a reflection of some sort of population specificity, but may also be due to small numbers of progressors in the validation cohorts. These are not easy studies to do and not easy to get sufficient numbers. And talking about progressors, the one in panel D is actually a signature that was published as a correlate of risk, so it was more about disease prediction. And this is the study. This was published by Zach et al. In The Lancet in 2016. So what they actually did is they compared people who had been exposed to TB, household contacts, and over time developed TB, and compared them to people who did not from the same cohort. And then they found a 16-gene risk signature that was predictive of disease progression. And it was validated, as you can see on the right-hand side, in various sets. And it actually, it looked sort of reasonably well. But then the interesting thing is, so how does that compare to these other tests that are for diagnosis? Now we're suddenly talking about prediction. Now the interesting thing is that this test behaved better in terms of performance the closer you get to the moment that the progressors get tuberculosis, as you can see here. So it's the solid blue line on top is the ones that is when they is tested within a year before getting tuberculosis. And Tom Schreiber from Cape Town actually gave us these wonderful graphs. It actually shows in that same cohort that over time, and on the right-hand side of those graphs is the moment when these people got tuberculosis, that already for a year or more there were changes, all sorts of immunological changes. So there were changes in, for example, you see on the left change in monocytes, in granulocytes, in monocyte lymphocyte ratio, and on the right-hand side in the T cell subset. So this was already going on for a long time. And then if you call that a correlate of risk, the question is actually, what is our model of risk? Are people predestined to get tuberculosis, and you can test for that? Obviously, we know that if you have HIV or diabetes, you have a bigger risk, but otherwise, I mean, are we predestined and can we test for that? Or is it just something that happens? Is it just bad luck? And my personal idea is actually bad luck. So on the left, you see the graph I showed you earlier. So this is the all these various stages. And what probably happens is what you see on the right-hand side, this comes from Hanif Ismail's paper, that there is probably something that turns your latent tuberculosis into something that becomes active, some sort of precipitating factor. And there's been a couple of precipitating factors that are now being studied, especially viral diseases. And I personally think that CMV, for example, plays a role here. Which means that what we test in and what they've tested in for that study is in that phase where there is already something going on. So they predict a future that is already happening, which means that those correlates of risk biomarkers are basically the same thing as diagnostic biomarkers, and potentially even for treatment monitoring. And with that thought, I would like to leave you. Thank you.